I don't need to this very selected group explain what is Alzheimer's. It's the most common neurodegenerative disorder in elderly people. But it is important to know that the budget that we are investing to try to cure the disease is very huge, at least in Western countries. Data mention about $100 billion in USA, especially I think after Reagan, the last Reagan got the disease in USA. Now, among the different types of dementia, is the most common. It's about 55% of autopsy cases. The second one today we know is Lewy body dementia and also vascular dementia. And today in the morning it was very nicely presented, and also yesterday, that a lot of cases with AD is not only dementia, it's actually mixed type of vascular plus Alzheimer's lesions. It was published in Lancet 2004, a very long-term study concerning the benefit of donepezil, and the conclusions were that donepezil is not cost-effective when they compared it with placebo, 4 years the study, with benefits below minimally relevant thresholds. The conclusions were clear-cut exposed. More effective treatments than cholinesterase inhibitors are needed for Alzheimer's disease. Transcranial magnetic stimulation is a relatively new technique for non-invasive and painless brain stimulation. The application produces electromagnetic field in the brain that induce, if applied repetitively, a modulation in brain cortical excitability. Actually, FDA and also the European yes, they have accepted it as a treatment for resistant depression. And we know today that when we apply high-frequency conditions, we increase the LTP, and this was proven. So, as a consequence, we think that memory impairments, and this was published by Pasquale Leone about 2 years ago, results from depleted LTP mechanism, and RTMS that we apply promotes LTP mechanism. This is the mechanism. And learning, as a consequence, is enhanced under such TMS conditions. So, based on the information available, we hypothesize that the treatment combining cognitive training with RTMS may result in a synergistic effect which might be more significant than that obtained by applying either cognitive training or TMS separately. The study was conducted at Asaf Harofeh Medical Center in the unit for memory problems. The patients were treated for 6 weeks with daily treatment, 5 days each week. Fridays and Saturdays, they didn't get the treatment. And later on, they got 3 months of bi-weekly maintenance treatment. Good. We started with 8 patients. The characteristics are presented here. We perform a brain MRI with each patient, and later on the images were adapted in order to establish in a personal level the centers to be stimulated. So each patient got a specific area where he will be exposed to TMS. The areas that they were stimulated you have here: Broca, Wernicke, right and left dorsolateral prefrontal, and right and left parietal somatosensory. The cognitive training was developed by the psychologist of the neuronics, and actually the study was supported by neuronics, and I think that they help us very much in the department. Now, the system included specific tasks that each patient performed according with the site of stimulation. And what are the results? ADAS-Cog improved from 22.5 at 6 weeks 18, and at 4.5 months 18, which means 4 points in the ADAS-Cog. Here you can see the results that they were significant. The CGIC was also significant at 4.5 months, which means that you remember that 4 is no change, and below means that there is an improvement. It is worthwhile to remember that the average improvement registered for drugs currently in use in the same period of time is 2.7 points according with ADAS-Cog, which means that actually in the same 4.5 months we got better results. Conclusions: according with the present study, rTMS combined with cognitive training, in our view, represents a new non-pharmacological tool which may be useful to improve cognitive functions in AD. Double-blind studies are presently conducted in our hospital as well as other European centers in order to confirm our preliminary findings.